Thank you so much. It's great to be home. I want to, again, thank my host has offered such great hospitality. Want to also, again, thank Mr. Hirsch, Dr. Mass, Judge Kuhlthau, and again, all those who've been so hospitable to me. I have been asked to keynote the conference this morning and to provide perhaps some framing questions and considerations for this very interesting topic of cultural and religious perspectives on end-of-life care and diverse answers to universal questions. So these are my disclosures, as been indicated, I will not talk about any unapproved medications or drugs. And our learning objectives here are listed, and I'm going to particularly focus on how goals of care can be bridged with faith traditions and how we express respect for patient autonomy in the process of guiding patients and families through the journey of living well at the end of life. And I wanted to start with a case, actually. This being Grand Rounds, that's often a tradition in Grand Rounds. So here we have an 80-year-old African-American man with multiple myeloma. He was managed with multiple rounds of chemotherapy. Because of his age and comorbid medical problems, he was not a bone marrow transplant candidate. However, he had much chemotherapy-related toxicity. The medications that were used to treat his cancer caused a significant neuropathy, peripheral nerve problems that led to frequent falling. He had orthostatic hypotension. His blood pressure would drop significantly as a result of an autonomic neuropathy related to his chemotherapy. At his visits back and forth to his doctors, there were lots of euphemism-filled conversations about his prognosis, and goals of care were never really adequately discussed. And this went on for multiple clinic visits and hospitalizations over a 3-month period. And I would say, by the way, he was a very religious man, usher and on the deacon board of his church. He actually also got relatively infrequent visits from the church members. He died in the hospital with renal failure related to complications of his disease about 2 years following diagnosis. At the time of his death, dialysis was being attempted at the bedside. Although he had completed an advanced care planning document, the clinicians caring for him seemed not to have any awareness of that. And there were, throughout the course of his care, no palliative care or hospice referral. Now, I would suggest to you this is typical, and I've titled this Usual Care. And there are many problems with this, but among the problems I would want to highlight is that his goals and the goals of the family were either not determined or ignored. Certainly, his notions, his understanding of his faith and how that might impact the journey that he was on while seriously ill was certainly never really discussed or explored in any serious way by anyone on the hospital team and in the clinical team. Treatments were often given in which the risk often outweighed the benefits. As I said, he got chemotherapy far into the course and was having significant autonomic neuropathy and falling. Literally fell down several times to get at his last visit to his doctor. There was much preventable suffering and indeed many wasted resources. So this is problematic, right? This is a problematic course. And I want to contrast this to what we know from empirical studies about what patients and families say they want when faced with serious illness. So this is from a study done actually by a colleague of mine at Duke, Dr. Karen Steinhauser, published now 15, 16 years ago in the Journal of the American Medical Association, in which she studied 242 patients, surveyed patients in the hospital wards and in the critical care units at Duke University Hospital, and asked them to rank what things they saw as important in their care as they were facing and walking this journey through serious and indeed terminal illness. And here's what they did, and this is basically in rank order. They listed being free of avoidable physical pain as a major issue. Being at peace with their God was a second most rated goal. Having the presence of their family near them. Being mentally aware, not being treated in such a way with medications and the like in which that clouded their ability to relate to their family and their loved ones. Having their treatment choices respected and followed. Having a sense that their finances were in order. Having a sense that someone, family, loved ones, even in fact the clinical team, were acting in ways that gave them a sense that their life was being affirmed, that their life in fact had some meaning. To the extent that there were unresolved family issues and conflicts to be resolved, they wanted those at least assessed and dealt with. And when the end came, they wanted to actually be not in a hospital, in an institution, but at home. So these are what patients and families say they want. Now contrast that with the case that I just presented, and very few of these goals were even elicited and certainly not met. Now, the historian and sociologist Philip Ayres wrote this very interesting book many years ago, The Hour of Our Death, in which he contrasted what he would call in the past deaths before the modern technological era as tame deaths. And he characterized these as deaths that were, in general, simple and often public. And there was a sense that the person who was ill and dying was doing this in the context in a social unit in their community, not alone in a hospital bed. That people were in fact active participants in their journeys at the end of life. The meaning of their journeys was rendered meaningful by ritual, often religious ritual. The great fear at the time was fear of alienation from body, from community, and from God. He contrasts that with what he calls wild dying, and what I would call medicalized dying, that is particularly noteworthy after the technological era ushered in by post-World War II, where deaths now tend to happen in hospitals away from the community, although there's some reclaiming of that with the inroads of modern hospice and palliative care movement, but still it certainly hasn't penetrated to the degree that I think most of us would say is optimal. Where the rituals are no longer necessarily religious or spiritually guided rituals that happen to people at the end of life, but they're mostly medical rituals, rituals around the white gown, and the ways in which we conduct ourselves in rounds, and that there's clearly a sense that death and dying, rather than being events which occur in the life of a human as part of a community, have now been really more framed as medical events. So deaths are medical events. And the reality is that the same fears of alienation from body, community, and God often occur, and actually to a more significant extent, that there is, because of the nature of the way in which we have been caring for the seriously ill and dying, that there is premature alienation from body, community, and God. How did we get here? Well, I would want to pose a question that we can perhaps ask throughout the rest of the symposium. Is this just medicine's fault? In fact, whose responsibility is it really to teach us how to come to the end of life, to teach us how to die? Certainly we can blame what we often talk about at the Duke Divinity School as the Baconian Project as being responsible for some of this, for a lot of this. The Baconian Project being the name for what we call the technology-driven methods and procedures by which we often approach even those who are hopelessly ill. Of course, this name being linked back to Francis Bacon in the mid-17th century, which names this effort to eliminate, essentially, human mortality and vulnerability to suffering by means of technology. Bacon started us on this path by doing some very important things, naming the scientific method, was being, of course, a very important one. But Bacon talked about that science would ultimately free patients from being, quote, overmastered by their disease. Now, although I've certainly worked and continue to work in the most high-powered, medical, research-intensive medical institutions, and I'm quite proud of that. And there is no question that I think we have an obligation to advance medicine and science and and to use the advances in medicine and technology wisely. But I think we would all say that we fall victim to this hubris, right, of feeling that if we just knew a little more, we could in fact finally overcome the fundamental reality of human finitude. And I would suggest to you that is hubris. So, how then do we begin to, should we be thinking perhaps more in better ways about caring for the seriously ill and dying? Of course, we have the principles of biomedical ethics to help us. I was telling the seminary students last night, there's a big joke in medical ethics. And here's the joke. There's 4 cardinal principles of biomedical ethics. There's autonomy, and I can't remember the other 3. Right? And of course, as Childress and Beecham basically developed, there's autonomy, which derives out of a fundamental respect for persons as one cardinal principle. There is the principle of beneficence, to do good, of the 3rd principle of non-malfeasance, not to do harm, and there's also this principle of justice as well. And we often, so often when we are practicing medicine, when we are counseling and advising patients through some of the most difficult and vulnerable parts of their life, often get stuck in autonomy, and I would say sometimes don't fully consider the other equally important principles. Then there's also this notion of dignity. Now, dignity is an interesting concept, and there are those who are in bioethics who think very differently about notions of dignity and how we should think about the concept of dignity as it applies to caring for people in their most vulnerable states, particularly at the end of life. So we have a very famous bioethicist, Dr. Macklin, who wrote this very interesting paper that said dignity is a useless concept. And her basic point of the paper was that appeals to dignity, and I quoted her here, are either vague restatements of other more precise notions, and here the notion she's specifically referring to is autonomy or respect for persons, or mere slogans that add nothing to an understanding of the topic or really don't add a lot, in her view, to guidance of how we as clinicians should behave and advise patients and family. On the other hand, you have physician, philosopher, scholar Dan Sulmazy, basically framing out and articulating a much more nuanced and developed construct of dignity. Dr. Sulmazy talking about we can think about dignity as being intrinsic, that is to say, the worth or value that we have simply because we are human beings. And I certainly think that that's important. He also articulates that we often also attribute dignity to people, and there are some times that can get us into trouble, but attributed dignity is, of course, the worth or value that we give to a person that is essentially a created value. Harvey Chachanoff, Dr. Chachanoff at University of Ottawa has basically done this wonderful work looking at actually studying what he calls dignity conserving therapy, and looking at characteristics of the way in which we behave and which we can measure the quality and the process by which we provide care to the seriously ill and dying from this perspective of dignity and how we then attribute dignity to others. And then Dr. Sulmazy talked about dignity in another slightly different context than attributed dignity, something he called inflorescent dignity. And by this, he's really talking about the way we tend to think about or attribute the worth or value of a person that is conducive of human excellence. So-and-so approach their death in a dignified way. That kind of highlights a sense of excellence or something of high value in the way in which the person approached or behaved. So I would suggest to you that some of the ways in which we minimize the risk of medicalizing death and dying and suffering is to recall, some of the ways in which are to recall the four great principles of the way of ethics and that guide us in the way we should treat people, and to also reclaim a notion of what it means to understand dignity in the way in which we provide care. I want to go back to autonomy, though, because that has been one of my, I think, an interesting observation. My joke, there's autonomy and I can't remember the other three. No lesser light than Dr. Atul Gawande has also had some interesting things to say about autonomy. I think you all know Dr. Gawande. He's a physician, ethicist, surgeon at the Brigham and Women's Hospital. He's written some very highly acclaimed books, Complications being one, which details his experiences being training as a surgeon. His latest book, Being Mortal, talks about the kind of limitations that his training imparted in him to fully care for people who are dying, and he chronicles actually the death of some of his patients and even his father, and pointing out some of the limitations in which he says many physicians are limited in the way in which they approach people who are dying. But he makes this interesting point in one of his books, Complications, in this wonderful chapter called Whose Body Is It Anyway?, in which he's actually asking us to push back a little on our traditional kind of notions of autonomy. And he makes this statement, which is, it's a provocative statement. And he says that he's actually calling for a more nuanced kind of understanding and implementation of what we mean by autonomy. And I wonder what my colleagues who in clinical ethics would think about this. But he makes a statement that, a good physician cannot simply stand aside when patients make bad or self-defeating decisions that are, in fact, decisions that go against their deepest goals. So although he's not calling for a return to paternalism, he is saying that there is something about being a good, responsible physician, clinician. I would just throw in also any healthcare professional, and I would definitely include nurses here, that do we not have an obligation to be more affirmative in guiding patients in a direction that we think is, I don't even like the way this is coming out of my mouth, to guide patients in a direction that we think is a better direction, particularly, he would say, if we have a sense that patients and families are making decisions that seems to be against their stated deepest personal goals. In his book, he actually talks about his son who had as an infant, had a significant complication, and he actually was critical of the physicians caring for his son because he thought they were asking him as a father to make too many decisions or were pushing kind of this notion of autonomy too far and not actually guiding him enough in terms of helping him understand what his goals might or should be, and then how they should be carried out. So interesting question. Now, I think this is in the backdrop of what many of my colleagues who work in theological ethics at the Divinity School would say is another problem with the way conventional bioethics have come to be practiced. And here's a quote from a colleague of mine, Dr. Farr Curlin, who's a physician and a professor of Christian ethics in the Duke Divinity School. Farr says, conventional medical ethics has largely given up on asking what it means to be human and to live well in the face of suffering, illness, and death. Such questions are treated as outside the realm of professional consideration. Farr claims the medical community has defaulted to human choice or autonomy as the activity that gives moral sense to our actions. If an action is chosen by the authorized chooser, the action is by definition ethical. If not, it's not ethical. And Farr is asking us to push back on that, right? And that is also consistent with other kinds of criticisms of conventional ethics, particularly as they have been applied to end-of-life care by other theologians. So here are some quotes from a late colleague of mine, the late Alan Verhey, who's a theologian and at the Duke Divinity School. And Alan wrote a number of really interesting books. One book I would recommend is a book called Reading the Bible in the Strange World of Medicine, which is fundamentally a critique of conventional bioethics. And his last book that he wrote just before he died is The Christian Art of Dying, Learning from Jesus. And here Alan writes the following in terms of observing what he thinks is happening in hospice, in modern hospice care, with kind of the permission of ethics, bioethics. He said, ironically, even in this cherished tradition of hospice care, which is the most compassionate model of caring I think we have, there is a risk of medicalization. The medicalization, risk of medicalizing the suffering. It is an instance of the old problem of the failure of our successes or the vices of our virtues. As the success of the Baconian project led to cures for many who had been overmastered by diseases and to medicalized death, so the success of palliative medicine has led both to great advances in pain management and also the risk of reducing suffering to pain and reducing the care for the dying to the management of their pain. Dying without pain is important, and effective pain relief makes an important contribution to the possibilities of dying well, but dying well and faithfully cannot and should not be reduced to a death without pain. So in many ways, Alan is again calling for a reclaiming of our understanding of death and dying as human events, right, and not as medical events, and is criticizing how certainly some aspects of hospice and palliative care have come to be practiced. I'd like to switch gears just slightly to pick up on my kind of final point before closing. Practicing medicine is hard. And it's hard because it's a demanding profession and we are challenged to care for human beings. We're not challenged to care for molecules in a test tube. And I have this famous, my favorite saying as I think about this is this following. Every person is like all others, like some others, and like no other, right? So we all have a common humanity, like all others. We all have our tribes and customs and cultural groups, like some others. And we're all the unique individuals that our DNA represents in us, right? And that our own personal experiences have led us to become. And I think in practicing medicine, we actually have to address kind of all these identities simultaneously in a person. So it shouldn't surprise us that different humans think differently about preferences and values at the end of life in terms of care. So here's a study from the California Healthcare Foundation published in 2008, which asked hypothetical questions of different racial and ethnic groups in California about some of the things about whether or not it would be appropriate for physicians to, quote, allow someone to die if they had a hopeless prognosis. So I don't think it should surprise us that different racial and ethnic groups think about this differently. So in this chart here, the light blue, the Carolina, not Duke blue, are the percentage of people who are saying that it's okay to allow someone to die. The pink is always do something, and the Duke blue, dark blue, it depends. And so you see, whites are actually, in this survey, were much more, a greater percentage of whites would say it's appropriate to allow someone to die who has a hopeless prognosis, whereas Hispanics, African Americans, I don't know why they, Asians and Chinese, I'm not sure why they distinguish Chinese from other Asian populations, but a lower percentage of these groups did not endorse the notion of being, quote, allowed to die. Here's this really intriguing study from black and white physicians. These are physicians. I think this study really has to be repeated. It's an older study, looked at databases in both the National Medical Association and the American Medical Association database, surveyed physicians, and asked things like, do you feel that tube feedings are heroic? Yes, no. Do you think physician-assisted suicide is acceptable? Yes, no. And given a scenario where you personally were in a persistent vegetative state and then had some medical complication, an infection, would you personally want to go to an ICU, get intubated, go on triple dose antibiotics, etc.? And you see, the interesting thing here is that there's a spread, there's a difference. Black physicians and white physicians answered these questions differently. Now, to be sure, with the exception of our tube feeding's heroic, which barely a majority of white physicians endorse that view, most physicians, black or white, do not, don't endorse these scenarios. But there is a difference. And the question is, why? And I think we don't fully know why. I think that there are social issues, I think there are religious issues and perspectives that play into this, and there's lived experience that plays into this, but there's a difference. And I think the question then becomes, how do these differences in perceptions and values play out as patients and families are being counseled and advised? So again, it shouldn't surprise you, given this, that if you look at who uses hospice, there's a tremendous disparity in this country. Although there's great regional variation, if you look in aggregate, hospice is still utilized mostly by whites. And if you look at Medicare decedents, and if you look at a national sample, the overwhelming majority of people who use hospice are whites. So what is this about, and why does it matter? Well, it matters because I think data shows that hospice and palliative care are in fact quality care for people at the end of life. If you look at the Institute of Medicine criteria for what constitutes quality health care, from the perspective of care being safe, being beneficial, being patient-centered, timely, efficient, and equitable, we have data now that hospice and palliative care meet almost all of these criteria. The only criteria which is not fully met, actually, is the equitable aspect of that. Here, this is the famous study by Dr. Timmel at Mass General. She's an oncologist, and she actually showed that if you take a population of lung cancer patients and you give early palliative care versus standard care, there's actually a signal that suggests that people given early palliative care, counseling, attention to symptom control, etc., actually live slightly longer than people in usual care. And my colleagues at Duke here published a study in which hospice and palliative care administered relatively early in the course and not within the last few weeks of life, not only produced higher satisfaction scores, but also saved money. So there's overwhelming data that hospice palliative care is beneficial. So to the extent to which some people in the population don't use it or have access to it, that's a problem, correct? I suspect that some of the resistance, at least in African Americans as I've studied it, has been on that, on kind of weighing that other great principle of medical ethics, justice, okay? So here's a quote from Pastor Frank Jackson, who we were surveying to develop a curriculum to address end-of-life teaching and clergy. And he said, everybody wants to go to heaven, nobody wants to die. It's not so much the act of dying itself, but the things surrounding death: injustice, poverty, mistreatment, and evil. There's a sense that we won't be stopped by these things. He called it our somehow theology. Somehow, some way, we will get through this. He says this is what he teaches his congregation. So my question to us is, how do we talk to Pastor Jackson and the people in the pews about hospice and palliative care in the framework of a somehow theology? And, you know, I'm sure Pastor Jackson couldn't have quoted this study, but here's a study I'll quote to you. This was a report in Health Affairs a few years ago by David Satcher, former Surgeon General, and several co-authors. They looked at models of rates of death from common medical conditions and concluded that if blacks and whites, if the gap between the rate of dying for basic condition among blacks and whites were equal, that would have translated into 83,000 deaths per year being saved in African American populations. Over the course of a decade, 830,000 deaths. So Pastor Jackson couldn't quote the study, but Pastor Jackson's and his congregation's lived experience was, this is why we have to talk about a somehow theology. And I was telling people the other day, I was at a conference of physicians, and someone got up in the audience and said, oh, so now you just want us to get comfortable with dying. Forget about all the unfairness in life, just get comfortable with the fact that you're gonna die early. Very provocative, right? I'm gonna move past this because I'm running out of time. But let me just first say this. With respect to African Americans, we've got this really interesting data emerging from the Pew Research Center that actually among all racial and ethnic groups now in the United States, it is the case that African Americans are the most religious, and in terms of the percentage of population that endorses a particular religious belief or endorses church attendance. And at a time when mainline Protestant attendance at mainline Protestant denominations was declining between 2007 and 2014, this number actually stayed relatively stable to slightly uptick in those 7 years. In actually studying beliefs and spiritual beliefs that might impact end-of-life care in African American populations, as was done by Kimberly Johnson several years ago, you get these themes emerging from these studies. Only God can decide life and death. God is responsible for health, which is interesting because that's actually a message which is a little bit at odds, right, with no, God, we are responsible for promoting our health. Spiritual beliefs are the most effective way to influence healing. There are religious prohibitions against limiting life-sustaining therapies. There's a belief in divine interventions and miracles. But very interesting here, the doctor can be God's instrument. So it's almost, people are holding these interesting views, right, in tandem. And in closing here, I'm going to say that as we think about religious and cultural perspectives on care at the end of life and in how we think about that, how we support patients, I think it's all about hope. But as Shakespeare said, the miserable have no other medicine but only hope. But the question is, what do we mean by hope collectively? I mean, there's an eschatological hope that I, as a Christian, certainly believe. But I'm talking about hope before we cross the River Jordan here. I'm talking about a hope about how we are cared for as we are in the last phases of life. I think too often we've thought about hope, and again, in a very medicalized way, the next important drug, right? Václav Havel, the Czechoslovakian president and author, said this about hope. Hope is definitely not the same thing as optimism. It is not the conviction that something will turn out well, but the certainty that something makes sense, no matter how it turns out. And I'm going to paraphrase Robert Frost, who said, hope does not lie in a way out, but in a way through. And I think we clinicians, we chaplains, we nurses, we physicians who are willing to get our hands and feet dirty and stay in there and a way through with patients actually are a source of hope-giving. So I think, to me, what I found in dealing with my patients is if I can reframe a hope, that is a hope of not being alone, a hope of not being in pain to the extent that we can avoid that, the hope of reconciliation, the hope of affirmation, and the hope of getting to a place of peace, then I think we are reframing death and dying as a human event. As a former colleague of mine, dying is a spiritual event with medical implications, not vice versa. And I think most of us clinicians in the room would agree that our training is really exact opposite of that, typically. So let me end by saying I have this great privilege of going to work in this building every day. This is the Duke Divinity School. This is actually the Westbrook building of the Duke Divinity School. Reverend U. Westbrook was a Methodist minister who founded one of the largest hospices in the United States and gave a huge gift to Duke to build this addition to the Divinity School. If you walk through that door, you come to this beautiful foyer and stairway. As I was coming through one day, I saw this. There was this shadow projected on the floor, and I said, isn't this neat? To me, this represented a DNA molecule. To others, it's infinity. But I said, here we are, School of Theology, Divinity School, and a DNA shadow on the floor. And to me, in that moment, just captured that, as a physician walking these halls, as a scientist and in conversation with other social and natural scientists, it makes sense that we should be in conversation across disciplines to promote human health, well-being, and flourishing, even in death. And on that beautiful arch there are passages of Scripture And this is a passage from Romans 12, in the New Testament. Be transformed by the renewing of your mind. It's just a wonderful passage of Scripture. And I think that we can all be transformed in the way in which we think and care for patients by listening to the story, by getting out of our medical boxes, by conferring with our colleagues in spiritual care, chaplains, community-based pastors, and by learning as a community to advance the care for the seriously ill among us. And with that, I will stop and thank you for your attention.